And certainly thank you to our panel here today. Just going over some of my notes here and biography statements for our panel here. I see FFS, NSQIP, ACS, ASNC, NQF, CSAC. Of course, we're talking about SGR in a place called DC. But I only mention that because I think it's a reflection of some well-intending efforts of those associated with government to try to create a better situation. And yet SGR, although well-intended, has not been impacting the situation as we would prefer. And it's very compelling when I hear that patients themselves, for which there's no acronym description, are seeing reduced access because of the obvious fiscal realities that exist. And that's without the next wave of healthcare reform efforts that I already sense are seeing some resistance. So with that said, I also know that we're seeing some consolidation in healthcare. Physicians kind of leaving their independent practices to join larger practices, whether or not under hospital umbrella or not. And I'm concerned that patients may not benefit from these changes. And so if you could perhaps elaborate, when you take the consolidation issue, whether it's in rural areas or urban areas as well, what is the impact with SGR, whether you think it does not have any relationship whatsoever, or patients should not be concerned, or providers themselves should not be concerned, if any of you would like to respond. Dr. Cutler.
Well, the ACP doesn't have policy on this, but just personally, I've been on both sides of the fence. I was self-employed. I owned my practice for most of my career. Just recently, I've begun to work for a small hospital network. I think the key really lies in the physicians, whether it's a two-doctor group or hundreds of doctors, the physicians being able to make the decisions that are best for their patients. So in a network like mine, which has a great deal of physician input into the decisions that are made from a business standpoint, I feel quite comfortable working there. If the physicians are not in charge, I would worry about a system like that.
Dr. Williams.
Yes, thank you, Representative Smith. As an imager again, on the hospital side, university side, I've watched the influx of physicians that during this consolidation, and the concern is that as Medicare has decreased payment to the fee schedule, less than the hospital outpatient prospective payment system, drives people into a system that ultimately costs Medicare more money. It does cost the patient more money to come away from their physician to a major facility in terms of travel and time, but more importantly, it takes away the on-site freedom of practice sort of environment that has allowed the imaging to flourish and to help people. Now, obviously, some things had to be reined in. There was a time when that nuclear cardiology, probably sitting at this table only because of this, it was the #1 Medicare expenditure. That was about 2004, 2005, before the fees were cut dramatically. The volume has gone down largely because of appropriate use criteria and getting people to certify in their specialty and to make sure that labs were accredited. That was the MMA of 2010. And if you're not accredited, you're not allowed to do nuclear cardiology and other imaging. And so the quality measures really can impact in a positive way how much Medicare spends. Thank you.
Dr. Hoyt?
Mm-hmm. Yeah, I think, in specialty care, particularly in surgery, we're seeing a trend toward employment as one form of this. And when you add to that then bundling of payments to entities or systems as a potential reimbursement model, you create on the one hand, some real advantages so that somebody that's part of a bigger system doesn't have the investment costs in electronic medical records, that they may feel less burdened by liability in a more protected environment. But I think the concerns about being able to perform at a quality level are really the same, so that we really need the same tools to be able to motivate people to perform quality care.
Very briefly, Dr. Cornier.
Yeah, it really depends on why they're coming together. We're going to see examples of groups that come together with the objective of serving patients well and competing in an environment where quality and good use of resources is the reward. They're going to do great. We're going to see examples of individual single physician practices who also do great in that environment. We're also going to see examples of people coming together to exercise leverage that may not be as good. It really depends on their objectives and whether they're led in a way that is in the interest of the patients.
Very, very good. Thank you. I appreciate, and certainly it's my objective that this panel doesn't come, or anyone else doesn't come between you and your patients. Thank you, Mr. Chairman.
Thank you.